Yeah, absolutely. So I went to medical school at the University of Toledo. I had studied philosophy and theology actually as an undergrad, and then actually got a master's in philosophy. It was around the time of September 11th, I think, when I was a junior, and about the time in college, and about the time that I was deciding on what to do with the rest of my life, and ended up settling on, I think I'm going to pursue medical school. Um, and because of the whole September 11th context, a lot of people were interested in joining the military. I think more so, there was that solidarity at that time than at other times in, at least the history of my life thus far. I was very close to joining the Marines so that I could become a translator because I loved languages. And eventually my family convinced me that I shouldn't do that and should continue on with education. So as I finished my undergrad and did the coursework that's required for medical school, I went and got a master's in philosophy, like I mentioned. But joining the military always like stood in the back of my mind. I'm a patriot, I guess. And so when the time came to apply to med school and I got in, it was kind of a natural step for me to join the Air Force, and to serve my country, in that way. So, the Air Force and military medicine in general is interesting because the patient population, is very healthy. You have a lot of health standards, fitness standards to be on active duty, and even the family members that you treat. There just tends to be a very positive health promoting culture. And my residency training in OBGYN was a combined military and civilian program. The civilian side of things is probably where we spend about 80% of the time. And it's inner city, Dayton, Ohio, which itself has been affected significantly by opioid addiction. And back in 2012, I think we saw a lot of like meth, and in any case, lots of exposure to addiction in pregnancy contexts. The 20% of the time I spent at the base and then subsequently on active duty service, I did not see much addiction at all, certainly not in the pregnant population. And, the military, for all its positives, does have some tension in terms of the culture around alcohol. Sometimes there's a little too much, I think, promotion of, events being kind of centered around drinking. But that didn't tend to be an experience I would take care of clinically. In fact, I'm pretty sure 4 years on active duty at Scott Air Force Base, I saw one positive urine drug screen, and it was for marijuana, like isolated throughout one entire pregnancy. So it's a different experience than maybe somebody who treats veterans in like the VA healthcare system, or perhaps psychiatrists in an active duty medical context. But at least on the pregnancy and women's health side of things in military medicine, there wasn't a lot of addiction exposure in my practice. So but this sort of sandwich existed where I had been exposed to a lot of patients who suffer from addiction during residency, and I just found that I always kind of vibed, as the kids say, with these patients. We got along well, and I don't know, they just kind of felt like my people, and so throughout my active duty training, it always sat in the back of my mind, like, man, I really like, treating these patients. It's interesting. I think I do a good job, like, connecting with them. Um, and when I got out in 2017, came back to my hometown of Lorain, Ohio, which is close to Cleveland, and got into a practice context civilian wise that was very much like, residency, where we do have a huge problem with opiate addiction in the hospitals that I cover as an OB laborist. And that just kind of reignited my interest in treating addiction clinically. And so that started me in 2017-18 on the path of figuring out how I could get into treating addiction as an OBGYN. And I mean, I could go. Yeah. So, I mean, part of supporting National Addiction Treatment Week and specifically the message, treat addiction, save lives, for me, is there is widespread in healthcare, even, especially where it shouldn't be in healthcare, stigmatization around substance use disorders, specifically, and honestly, still a lot of things that relate to mental health. In pregnancy specifically, though, I feel that pregnant women who have a substance use disorder are some of the most stigmatized, abandoned, neglected patients that come through our hospitals. And part of this is, systems issues, access to, evidence-based treatments for opiate use disorder, for instance, aren't necessarily very robust in a lot of communities, like your, average middle America kind of town like that I live in. And so that's the thing I think I've seen the most is there is a kind of ad hoc approach to treating these patients, and that the addiction component of their lives, their experience of health or disease, is not treated directly. And when providers, clinicians, all throughout, like, the healthcare team encounter these women, I feel on the whole, the patients are left without encouragement, pursuing their health and their goals. Because I mean, my experience has been with pregnant women, just in general. Like, to me, I couldn't do it, like, literally, could not do it. But even if I could, it just seems way too much to deal with to gestate, bear, and then, raise kids. But there is something about, it seems, motherhood that really pulls women outside of themselves and really inspires them to, simple things: eat healthier, get rid of bad habits, try to get their schedule or lives in order to welcome a baby. Families tend to kind of rally around the woman a little bit more. So there's, this opportunity for encouragement. And so it provides a really opportune instance to kind of initiate treatment in a healthcare context. So yeah, so so I would say the state of it is one of slowly improving. So let me talk about my community. So I'm in Lorain, Ohio, like I mentioned, near Cleveland. So we're Midwest. The hospital where I practice is a community hospital. Our community lost 141 lives to overdose last year, and we were able to cut that down to 119 this present year. And I have been working as the medical director for an opioid treatment program for about 3.5 years now. And what I have seen throughout this time is, a lot of stories about how we could be better in the ER or in triage or in inpatient context with respect to, treating patients with dignity. But I have also seen that by my own efforts, just connecting with colleagues, whether it's, writing a letter to somebody like a consultant and saying, hey, I have this patient who is on, methadone for opiate use disorder. And then I've kind of developed a educational kind of list of bullet points like, hey, just wanted to let you know, this patient's doing well, or, if you're prescribing other medications that have sedative effects, like be careful. I would encourage you to, monitor, their EKGs, for instance, if it's methadone, and be careful prescribing drugs that do X, Y, Z. I feel that has helped other clinicians be willing to kind of treat these patients better, and that's the feedback I get too. Another simple thing I've done is just give my phone number to the ER director and made sure that, hey, if any of my patients come in to the ER, do you mind giving me a call just to let me know? And so that's provided a lot of opportunities, just to answer questions. Hey, this patient came in, said that they were not able to obtain the medication that was dispensed during dosing hours at our opioid treatment program. What do we do? And so then I, can take a couple minutes and be like, here's a little bit about the pharmacology of methadone, and, update them about the fact that they are allowed to treat people in opiate withdrawal without having any special license in an ER, at least up to 3 days. And those sorts of things, mostly education, communication, and networking with other colleagues has been helpful at improving the status of stigma within my community. Culturally, I would say that mental health is, huge now. Certainly, if you look at any content creation platform, there are so many people opining about mental health topics, addiction definitely being one of them. Not all of it's good. There's a lot of personal stories being shared, which I think do have value. And so the conversation is getting out there. I think the biggest problem is the fact that there's a disconnect between the world that people who suffer from opiate addiction in particular live in, and those who don't. And getting these two kind of communities to understand, especially the non-affected, people in our communities to understand the plight of those families and the individuals who suffer from addiction is something that we all can kind of do through, our sphere of influence, even if it's 2, 3, 4 people. If those 2, 3, 4 people are treating patients, then that does have a measurable, noticeable impact in a community or in a hospital system. So I could really ramble on this. So I myself have a media project that has like 20 plus podcasts and growing, and a lot of them are, all of them are focused on medical education, mental health, and like just pretty much anything health related. Media is where culture changes. I think that is patently obvious if you look at social media and the rise of it over the past decade. And it's not always for good. It's not always for ill either. I think that the greater interest in mental health topics with average real people who suffer from or know people who suffer from mental illness talking about this sort of thing is really effective at getting people to consider treatment. Just personal story, when I was in medical school, second year, going from philosophy to medical school was quite the adjustment. So there was a lot of stress involved, and I ended up suffering my own bout of depression. And I remember thinking like, I don't want to go see the psychiatrist at the school, because then people would know I'm seeing a psychiatrist. And I have seen throughout the past decade that sort of sentiment has kind of gone more and more to the wayside. It's still present. Honestly, it's very present, it seems to me, in physicians who personally, don't necessarily want to get treated for mental illness. But to me, this is all of a piece. So Ars Longa Media grew out of my work on one podcast I started in my bedroom, classic, called Inside the Boards. My goal was to help medical students prepare for their United States medical licensing exams by providing, on-the-go study resources, maybe save them a little time if they can, learn some stuff while they're listening to their headphones, working out or commuting or like brushing their teeth, whatever. But I did know that I wanted to do more or be involved in more things in media because of its potential to impact culture, and a growing sense that the sorts of media that was being produced is not necessarily helping our culture. For instance, have conversations between people who disagree on fundamental issues, which is a large part of what I feel I learned to do in my undergrad studying philosophy. And, definitely, I think we've all seen the polarization of culture in digital spaces. And so as I developed Inside the Boards and focused on helping medical students, I actually connected with ASAM back in 2020, I believe it was. And I was like, I want to do an Addiction 101 series for medical students, working with Dr. Kara Poland in Michigan, who runs the My Cares program, which kind of walks people who are attendings like me, who are interested in getting board certified through the practice pathway to board certification that the American Board of Preventive Medicine offers until 2025. For all you out there who may be interested, it's still possible. So we did this Addiction 101 series. I think the stats that at the time were that during medical school, the average student got something like 3-4 hours of specifically dedicated didactics related to addiction during the 4 years of medical school. And our podcast was getting like 15,000 medical students, roughly 10-ish% of medical students in their first 4 years on the journey to becoming a doctor. And we were able to do this series on addiction, which secondarily meant that I got to talk to a lot of people who know a lot more about addiction medicine than I do, and got a bunch of free great didactics. So there was that, but also a lot of, I think we made somewhat of an impact on getting the idea that addiction is a chronic brain disease. It belongs in the category of illness or disease. Medicine, presumably is devoted to the eradication of disease, the amelioration of pain, and the promotion of health. So kind of fits the domain of what we're supposed to do as doctors. I've always been concerned about medical students. I have observed with medical students that there is a certain idealism that impels all of us to go into this profession. And to a certain extent, it kind of gets trained out of you as you go through med school, then residency, and get into the trappings of the modern healthcare system. And I think that's absolutely tragic. I think it contributes to persistent stigmatization of people with mental illness and addiction in particular. And I think that we can use media to kind of change that conversation, to, ask questions that prompt more thought. Certainly to be able to show people that, it is, we don't really like to use the word crazy in mental health context. Patients do all the time, but I'll try to avoid that. But it is surprising, I guess, to me that we have medications that can rebalance the way a person's physiology is supposed to be. I see addiction as a disease of the will, and a disease that affects a person's ability to make a free choice. Like if you're compelled to do something, someone says you have to go rob the bank, or, we're going to harm your family, that in the law even, and certainly in like moral philosophy, diminishes a person's responsibility from a moral perspective for that act. The goal of treating addiction is the restoration of somebody's life, right? I tell patients, like, being able to help match who you want to be with who you are, which is kind of a universal human experience that just comes to light a lot more starkly in the context of treating addiction. But you can treat addiction. You can give medications. You can help encourage people to put things into their life that help them get healthy relationships, improve their sleep, eat better, exercise, have a plan for life. Addiction takes a lot of that away, often all of it, to the great detriment of, the social connections that people have. Thomas Aquinas, one of my favorite philosophers, defined love as willing the good for somebody else. And if addiction can be thought of as a disease of the free will, it just makes sense that addiction negatively impacts people's ability to love or to give themselves to others. And it leads to this just pervasive emptiness that it is incredibly rewarding to see filled with better things in life as you walk with a patient that you're treating. And that's just what I would like, charge my colleagues with, and especially medical students, to really consider as they're, setting up their practice. Like, number one, hospital may tell you to do X, Y, Z. However, you are a physician and you have primarily a moral set of obligations to practice your art for a patient's good. So you should not be content to do things that are less than what patients need. Hence, being involved in some sort of advocacy, within your own personal sphere of influence or larger, is important. But there are so many ways that you can improve the care of people who suffer from substance use disorders. The simplest is, not to be would be how I would put it to my patients. Probably a more appropriate way to say it for a medical professional context might be, don't be a jerk to people. It's kind of basic stuff, but meeting a patient, treating them with dignity who suffers from addiction, that might be one of the few experiences of that they've had in a while, or, as long as they can remember, or maybe ever. And a 10-minute ER interaction does not need to leave a patient, once they're discharged, feeling even worse about themselves, more shame. Like, what's that going to do? We are no better or no worse than any of our patients. We are supposed to be healers, and fight to hold on to that idealism that gets trained out of a lot of us throughout our journey to, becoming physicians. I've really actually turned my attention with the kind of like media content creators that we're trying to bring on to our network. And we're kind of moving Ars Longa Media, at least at this time, and I don't know if it'll continue forever, but certainly I don't have plans to really focus on much else right now than bringing together people who are talking about recovery or addiction medicine, who are involved in creating content to educate the general public, or physicians or other clinicians on how to treat or understand addiction. And so the passion project that I have been sketching out in loose ways initially, actually, when I remember the first call about this Medical Student Addiction 101 series, I still have like the little notes, but I was like, we could do this. And I was jotting things down, and it's taken shape as what we call our addiction recovery project. And that is 3 components principally that we would like to do. One is to create a new addiction recovery related podcast that will launch or that will comprise thematic seasons. So we do like addiction and the music industry, or addiction and comedians, or something that makes it worth listening to for a general audience, but has that sort of like didactic bent in terms of just educating people. And because I'm a physician, there's always this kind of like, how does this relate to health thing in the back of my mind. And so we want to launch this project with the first season of this podcast being focused on musicians telling stories of their own recovery, and how getting treatment improved their lives and impacted their art. And there's a lot of musicians and other creative types, like even a lot of my patients who, you know, their addiction may have taken their ability to complete their education. But, you know, it's like, hey, what do you want to do with your life? Or like, what are you into? And they're like, oh, actually, I draw. And I'm, you know, okay, well, what do you draw? And then they show me these elaborate, very talented things. And it's like, I, there seems to be, at least phenomenologically, a connection between people who have a tendency towards developing addiction and those who have gifts of creativity beyond a lot of us. And I don't know that that's something that can be studied in a randomized controlled trial way. But there is still data in terms of, you know, the experience that a lot of us have. I mean, how many songs deal with the struggle of a person against their, you know, demons, which, I mean, modern Juice World, that poor kid lost his life at like 21, to really severe addiction. You know, things stand out to me like Johnny Cash's version of Trent Reznor from Nine Inch Nails' song Hurt, where Johnny Cash made that song his own. And it was born a lot out of his own experiences, having an unhealthy relationship with alcohol. And so we want to find artists. We want to make an album of cover songs related to addiction and recovery. And then we want to put that out to the world and to third component support a cultural shift in how people talk about, view, or act towards all topics addiction. And to me, you know, supporting the Treat Addiction, Save Lives initiative is a huge part of that. Like, it's a simple message, but those are often the most effective. It's something that physicians can understand. It's something that patients can understand, and their families, who are often going to be essential components to getting people to get their lives back. So I have tons of them. But let me say this for people who are my colleagues or who are trainees in you know, their medical education journey. It's kind of the little things that are even more professionally satisfying, I think would be the term a lot of people would use. But those things that make me feel like I'm fulfilling my vocation as a doctor, the thing that I kind of thought my life would look like once I became a doctor, when I was a pre-med studying, like, you know, bio 101 sort of thing, where you don't have an idea really of what physicians do. And it's the fact that, you know, in my main clinical practice activity as the medical director of an opioid treatment program, we were focused on opiate addiction. And it has a very, you know, observable, definable natural history, the disease opiate use disorder does. But also it has a somewhat predictable and common improvements or a set of improvements that you see in terms of the patient's health as people get into treatment. And I mean, this is very general, but it's these little things day by day that I've learned. It's helped me to counsel patients when they come in. And, you know, if somebody comes to get treated for opiate addiction, um, they're there because if they don't take opioids, they're going to be sick. And, I'm sure I've heard people say, yeah, serves them right, or some negative stuff like that. But uh, we don't say that to other people. Certainly, if you had a severe flu or COVID and had all the muscle aches and severe vomiting and diarrhea and inability to regulate your body temperature. I mean, it looks awful. And it looks way worse than, what the average person experiences during flu season if they get, influenza or another kind of common infectious disease that we've all, have some experience with. And so you're talking to them and, they seem hopeless. They feel hopeless. They say they're hopeless. They're full of shame. It takes a lot to be like, hey, I have a problem with heroin or fentanyl, because that is embarrassing for people. It doesn't need to be. It is, I think, in large part because of the failure of physicians and healthcare kind of people to be places where people can share whatever they want or need to with somebody without suffering negative judgment or shame. But talking to these patients, being like, look, just give me 2 weeks on this medication, and I promise you, you will start to see a light. Right? It's going to take potentially years to get your life back or to get your life to where you want it to be. But if you can give it 2 weeks, you will start to see hope. If you can give it a month, just keep showing up, then you probably will find that you feel a little bit better about yourself. Like, you don't feel as bad about your past choices because you're looking forward to who to your potential and who you could become. You probably will have a little bit more money, which is a very tangible, practical thing, super helpful if you've, lost everything because of the disease. And then, this just tends to be the little thing you see every day. And that's really what stands out to me. Like, honestly, my patients thank me all the time. And I mean, pregnant women who don't have addiction are often thankful too. I'm not saying like my patients who don't suffer from opiate problems aren't thankful, but the frequency with which people thank me or thank like our counselors at my clinic or the nurses, it does seem to be like way higher a percentage, and a lot of it is just because we're treating them with human dignity. So yeah, that's what stands out to me. It's the slow things they get back. I'm taking care of an outstanding warrant for, possession of a substance. Now I can, pay a fine that's been looming over my head because our justice system seems to be built on a preferential option for sticking it to the poor. And, people get their licenses back. People get their kids back if they've had like interruptions in, custody arrangements. They cut off relationships that are unhealthy and learn what healthy relationships are and get healthy ones. They get jobs, they go to school, they enroll in a class of something that just interests them, which is a huge win to find something that interests you when you can't think of anything else about it than like not getting sick from a lack of opiates. So yeah, there are a lot of individual stories that are absolutely awesome and amazing, but it's kind of the day-to-day stuff that you get to see measurable improvement week by week, month by month that I think stands out to me the most and is the most rewarding part of doing this sort of clinical work.